Right, so hi guys, good evening and welcome to today's second Essential Examinations lecture. I'm Stephen and I'm going to be talking to you about the abdominal exam today. And what you'll be learning in a few moments, I'll let you guys know what the content of today's lecture will be, but I just want to reiterate again how we have got this really awesome series giveaway at the end of all of our lectures. All we require for you to enter this draw is to fill out the feedback form, and what we will do is we'll collate all of your names, and two lucky students will win either prize one or prize two. Now you might see that prize one has got, or both of the prizes actually have got attendances attached to them, or the conditions are attached to the attendance. I can tell you now that we've scrapped that. And so what we will do instead is anyone who attends a lecture, and however many lectures that someone attends, we will collate all of your names. And rather than one name, we will have, for example, if you attended 8 lectures, we will have your name 8 times into the draw, therefore increasing your likelihood of winning one of these awesome prizes. And we'll be letting the winners know towards the end of July after our last event. And yeah, so I would just like to appeal to you to please keep attending our live lectures. Please fill out the feedback form. It's always very useful for us. And you guys can win something really awesome at the end of this series. In terms of our sponsors and our partners, I'd just like to say a big thanks to all of our partners at the bottom, as you can see, who have kindly and very generously donated some of these gifts for you guys all to win. So yeah, without further ado, right, so today's lecture. So today's lecture is going to cover the abdominal exam. Now in this abdominal exam, I will be talking to you about the general inspection. After that, I will be talking to you about breaking down the inspections from all the way to from the head all the way to the chest, and then the abdomen, obviously. Then we'll talk a little bit about inspection and palpation of the abdomen, followed by percussion, then auscultation, and we'll finish things up just discussing the PR exam or per-rectum exam. And finally, we will, if there's any questions, I'm always happy to answer the questions. And I'll then send the feedback form into the chat and you guys can fill it out. And as I mentioned, two lucky students can win 2 prizes, which are really, really nice. So, general inspection. So what do we do in the general inspection? So the first thing that we should do is we should always get the patient to sit on the bed, and they should be nice and relaxed, and we should inspect them from the end of the bed. And what we will be assessing here is we'll be assessing their mental awareness. For those of you who are there for our first neurological exam lecture, I did talk a little bit about mental awareness and the Glasgow Coma Scale. So first thing is always to gauge how mentally aware the person is. Are they confused? And in the context of the abdominal exam, confusion could be a really common feature of liver disease and hepatic encephalopathy as well. The next thing we need to talk about is, are there any scars visible? And is the patient in any pain? Are they really uncomfortable? Where is the pain? And does the patient mind if we were to examine them? Following on from that, we will be talking about distension. So distension may suggest, for example, the presence of ascites or even organomegaly, and also bowel obstruction as well. Then it's always useful to assess the patient's skin color. So, for example, are they pale, or are they jaundice, or is there hyperpigmentation? So, for example, a pale color of the skin could suggest anemia. This anemia could be caused by gastrointestinal bleeding and even malnutrition. However, it is important to mention that healthy people can also have, pale skin or pale complexion. So not everything, or not every patient that you see with pale skin is anemic. So as I mentioned before, edema typically presents on the limbs, and it can be pedal edema, or it could be tibial edema as well. And this is usually associated with liver cirrhosis. And as a result, it's always incredibly important to assess the patient's lower legs for whether there is pitting edema, which could possibly suggest hyperalbuminemia, and then typically liver cirrhosis, protein losing enteropathy, and things like that. The next thing is the patient cachectic? Is there cachexia? So cachexia is ongoing muscle loss that is not entirely reversible, even with nutritional supplementation. And cachexia is usually associated with malignancies and also advanced liver failure due to dysfunction in creatine proteins, and things like that. And then the last thing is, are there any hernias present? So a hernia could be possible, and it usually is very, very evidently visible from the end of the bed. So in the following slides, I'll be talking to you a little bit about hernias. You might have noticed from the contents that there is no anatomy at the start of this lecture, and the reason behind that is I'm going to be adding snippets of anatomy throughout the lecture. And I think it will better aid your knowledge as the lecture goes on. This is general inspection. The next slide, we're going to discuss each of these inspections in a little bit more detail. So first thing here you can see is scars. So I'm not going to go into each and every one of these scars and the indications, but it's very important to visualize this scheme, for example, on a patient's abdomen. So in the top left corner here, just usually where the liver and the gallbladder is associated, you can see there's a Cochle's incision here. If you make an incision along the the right costal margin and also on the left costal margin, that is known as a rooftop incision. And all of these are usually for complex HPB, hepatopancreatic biliary operations. In the midline, we can see that there's a midline incision, there's a paraumbilical, etc., etc. In the right iliac fossa, we can see a typical gridiron incision, which is usually where the incision is made to take out an appendix. So it's usually an open appendicectomy. Lands, once again, dependent on the anatomical variation of the appendix. Phalansteal, which is which is what is used by obstetricians and gynecologists for cesarean sections. And yeah, there's also Rutherford Morrison, which is for more complex bowel surgeries. So it's very important to be able to identify these incisions and then to correctly name the type of incision especially when you're writing down notes and explaining to a doctor. The next thing is skin. So as I mentioned, you know, on the left side here, we can see that this is usually what healthy skin looks like. Perhaps in this patient looks a little bit more pale. And on the right side, conversely, you could say it looks more tanned rather than jaundice. But jaundice is, I think, most of the time it's very easy to spot and it's very blatant to spot. And I guess if you're correlating it with your bloods, a bilirubin of more than 30, it's usually clinically evident as well. And from jaundice, as I mentioned, you'd have a yellow or greenish skin, and then the whites of the eyes are usually yellow as well. Right, on to inspection of the face. So how do we inspect the face? First thing we should do when we inspect the face is break it down into the eyes and then the mouth. So in terms of eyes, we ask the patient or we ourselves gently pull down the lower eyelid. And when we pull down the lower eyelid, we are assessing the color of the conjunctiva. And paleness of the conjunctiva is usually suggestive of underlying anemia. Also, it could be jaundice, as I mentioned, the whites of the eyes. And if the whites of the eyes are yellow, that's usually one of the first signs of jaundice. The next thing is exanthelasma. So exanthelasma is yellow raised cholesterol-rich deposits around the eyes. And this is typically linked with hypercholesterolemia. In the next slide, I will be showing you these images of what exanthelasma looks like. And the final thing we need to look for in terms of the eyes are Kayser-Fleischer rings. So these are dark rings which basically encircle the iris, and they're associated with Wilson's disease. Wilson's disease, which we know is the accumulation of copper in the liver and then also various other organs and tissues. So in this image, you can see here what I mean. So this is the cholesterol deposit around the eyes, which are linked with high cholesterol. So this is exanthelasma. Yeah. This exanthelasma can sometimes in jaundiced patients be quite hard to identify. But as I said, if you correlate it with all of the bloods and if you inspect possibly with the light, these findings might be a bit more easier to see as well. And then on the bottom right, we obviously have a picture of the eye here, but these rings here, especially in this part of the eye region, are what are known as Kayser-Fleischer rings. And these are usually linked with Wilson's disease, which is a metabolic disorder of abnormal copper accumulation. Right, so as I mentioned, we're going to be talking about the eyes and the mouth here. So the next thing that we need to inspect is the mouth. So usually with this, we ask the patient to open their mouth, and we inspect the corner of the mouth for any signs of iron deficiency. Usually the iron deficiency here, or sorry, the lesion here, which is usually along the corner of the mouth, is usually known as angular stomatitis. So this is quite a common inflammatory condition, and this is linked with many deficiencies such as iron deficiency and also malabsorption. Next thing is enlargement of the tongue. So is there glossitis? Glossitis is a smooth red-like enlargement of the tongue, which is associated with anemias once more. So usually seen in iron deficiency anemia, B12 and folate deficiency. So the macrocytic anemias typically present with enlargement of the tongue. Another thing is, can we see any ulcers? What type of ulcers are we talking about here? We're talking about apathous ulcers. So apathous ulcers can either be round or they could be oval, and they're usually occurring on the mucous membranes inside the mouth. And these apathous ulcers are usually typically benign due to local trauma or stress sometimes, but they can be associated with anemias as well, alongside Crohn's disease. Hyperpigmented macules, which I'll be sharing an image of in the next slide, which are highly indicative of Peutz-Jeghers syndrome. Obviously, we know Peutz-Jeghers syndrome is a genetic disorder, particularly autosomal dominant, which results in the development of polyps in the gastrointestinal tract. So these are the 4 things that we're looking for around the mouth and in the mouth, which could be suggestive of gastrointestinal pathology. And here in this image, you can see in the top left, these are the inflammatory type lesions, which are usually seen in angular stomatitis, which can be seen in forms of anemia. And here on the bottom right, these macular type lesions, which are very suggestive and pathognomic for Peutz-Jeghers syndrome. Then we've inspected the face or the head. The next thing that we need to inspect are the hands. So the hands can provide a lot of clinically relevant information, and that's why we should always stress on having a focused and structured assessment to really properly assess if there is underlying pathology. So inspection-wise, palms. What are we looking for on the palms? We're inspecting for any paleness, so pallor, any redness, if there's any erythema, and also if there's any contractures. So no one quite knows why contractions such as Dupuytren's contracture are linked with gastrointestinal diseases, but there are. In terms of palmar erythema, it can be linked with chronic liver disease. It's usually one of the more significant signs of liver disease. And then the paleness of the palm, suggestive of malignancies, GIT bleeds, and malnutrition. Now, for the nails, so we're inspecting them if there's any koilonchia. So koilonchia is when the nail is spoon-shaped, so it's very round. And this is once again associated with iron deficiency anemia, for example, malabsorption in Crohn's disease, whereas leukonchia is whitening of the nail bed, which is associated with low protein, usually seen in end-stage liver disease, and also protein-losing enteropathy. Finger clubbing. So finger clubbing, we usually ask how do we assess for finger clubbing? So we ask the patient to place their nail alongside another nail, as I'm showing you here. And what usually happens is finger clubbing usually involves uniform soft tissue swelling of the terminal phalanx of a digit. And when there is some swelling on the digit, there is usually a loss of the normal angle between the nail and the nail bed, and as a result, there is a curved type appearance of the nail. Once again, this is, I think the themes for gastrointestinal pathologies are quite repetitive, and this can be seen in IBD, celiac disease, and liver cirrhosis. The final thing, which I think is very important, is that, the final thing, which is very important, is assessing for asterisks or a flapping tremor, which is what most people call it. So, what is asterisks, and how do we inspect it? So, asterisks is a type of negative myoclonus, which is usually which usually causes a flapping motion of the hands, and it's usually seen in underlying causes of, hepatic encephalopathy or uremia, which is usually due to renal failure. And the way that we assess this is we get the patient to stretch their hands. So if you're looking at me, we get the patient to stretch their hands, and we ask them to cock their hands at their wrist. So we have it back. And what should happen is, if they are showing signs of hepatic encephalopathy, the hand should flap. It should fall automatically, like this. So we get them to cock their hands at the wrist, and if they are, for example, if there's renal failure and they're showing signs of uremia, and if there's hepatic encephalopathy, their hands will start flapping like this, like a tremor. And usually we do ask the patient to hold or to kind of clock their wrist at their hand for about 30 seconds if they can. And if they can't, this could also be a sign of hepatic encephalopathy. Right, that's exactly what I just mentioned. And here is a visual image representation of finger clubbing here, and the flapping tremor, or the asterisks, as I demonstrated for you. Next, we're on to arms and the axillae. So for the arms, is there any signs of bruising, which could be suggestive of liver disease, especially clotting dysfunction, which is usually quite common in cirrhosis? Are there any excoriations? So excoriations are described as scratch marks that may be caused by the patient who is trying to relieve themselves from all of the itching, and this can usually suggest cholestasis, which is usually caused due to bilirubin irritating the skin. Another thing that we should rule out or try to identify is, are there any needle marks, especially in the case of IV drug users, IVDU. Obviously, we all know that taking IV drugs off the street and kind of demonstrating risky behaviors is a risk of parenteral infections. And in terms of abdominal context or GI context, the main infection that we're worried about here is hepatitis. Just to make sure that everyone is alive and focused, can someone please comment which hepatitis is we're worried about in IV drug users, and also other infections which we're worried about in IV drug users, please? Next thing is the axilla. So in the axilla, are there any signs of hyperpigmentation, or is there thickening? Hyperpigmentation or acanthosis nigricans is usually suggestive of type 2 diabetes or stomach malignancies as well. Can also be hair loss. Hair loss is very suggestive of anemia and also malnutrition. Let me just check the chat. Yeah, everyone is focused and alert. That's great. Thank you everyone for commenting. This is acanthosis nigricans, which is hyperpigmentation. Now this image here is just of the axilla. What you need to know is that this could be in almost any crevasse of the body. It could be in the creases of the groins. It could be on the back. It could be behind the knees as well. So it's always good to try and analyze the skin. Obviously, in the axilla, we're looking for lesions such as this. On to the next. So we've done the head. We've done the hands and the arms. Now we're on to the neck. So inspection of the neck. You really have to know your anatomy just for this. Why do you need to know your anatomy? Or what is the most important aspect of anatomy in this? So why it's important to know our anatomy is so we can palpate each region of the nodes for lymphadenopathy. So as we know that there's numerous number of lymph nodes in the head and neck region, but we all know that these lymph nodes all drain different parts or different organs as well. The most important lymph node here is usually in the supraclavicular fossa. So the supraclavicular fossa contains Virchow's node, Virchow's lymph node, and enlargement of Virchow's lymph node, as you can see in the image here of this lady, is usually the first clinical sign of metastatic intra-abdominal malignancy, most commonly gastric cancer. So just assessing the lymph nodes, especially the supraclavicular lymph nodes, Virchow's nodes, are very important in trying to identify the diagnosis. And in general, there'd obviously be lymphadenopathy in signs of infections and things like that. So these are the lymph nodes in the head and neck region, which I've been telling you. So you can obviously see that there's preauricular lymph nodes, there's retroauricular, there's occipital, and then the cervical, and right at the end there's the supraclavicular alongside the lymph nodes in the mandibular region. Onto the chest. So what are we looking for in the chest? We're looking for spider nevi, which is usually associated with liver cirrhosis, but they can also be due to high levels of estrogen. So don't be alarmed if you see spider nevi in pregnant females or women's taking the oral contraceptive pill. It's quite normal. How do we define spider nevi? So spider nevi are usually skin lesions that have a central red papule, and they have fine red lines like spider webs, really. That's why they're called spider nevi. And I'll show you an image in the following slide. But they're red papular type lesions. Next thing, gynecomastia. So what is gynecomastia? So gynecomastia is enlargement of the male breast tissue, which is once again caused by high levels of estrogen, but it can also be caused due to side effects of drugs. The types of drugs that we're talking about here are digoxin and spironolactone, which is a diuretic. Another thing is hair loss. We obviously, I think we've all gathered now, hair loss can be caused by malnutrition, but it can also be due to high levels of estrogen as well. All right, so these are the spider nevi. I think this one is quite good to see. So this is obviously someone's chest, and this here is the red lesion, the red papular type lesion, which is more dense in the center, and it has fine red lines which branch off it like spider webs. This is highly indicative of liver cirrhosis. Right, so we've done the head, we've done the face, we've done the mouth, we've done the arms. Now we're on to the fun things, I think. Now we're on to the abdomen. So as I mentioned before, in the general inspection, the types of things that we need to look for. I'm going to be revisiting some of those in a bit more detail. So once again, we ask the patient to lay flat on the bed with their arms by their side, and we ask the patient to relax. Obviously, in a hospital environment with numerous students around you, it can be quite daunting. So as relaxed as they can be is really great for this. What are we looking for? So we're looking for scars, as I previously mentioned. The numerous different types of abdominal scars that can provide clues as to the patient's past surgical history. We're looking for distension as well. Distension can usually be caused by the 6 Fs. It's a good mnemonic for all of you students listening. So fat, fluid, flatus, feces or fetus, or a mass, so fulminant mass. 6, not 5. And those are the 6 Fs, which are usually lead to abdominal distension. Could be pathognomic signs as well for pancreatitis. I'm going to discuss those lesions in the next few slides. Also, other pathognomic signs could be, caput medusa. So caput medusa is engorged, or that they are engorged paraumbilical veins, which are usually associated with portal hypertension due to liver cirrhosis. We may also see striae. So striae are quite normal. There's nothing wrong with striae, but these stretch marks can sometimes be due to ascites because of the increased abdominal pressure. It can be due to malignancies because of the paraneoplastic effect. They can also be due to Cushing syndrome and pregnancy as well. Hernias, which I'm going to mention how to examine them and the types of hernias. And then finally, stoma, which we didn't really mention. And another thing we did not mention, which I'm remembering now, is it's also very, very important to also check for any tubes or if there are any drains attached to the patient. And along with that, I think it's also important to inspect whether they have a urinary catheter. Sometimes if the patient is wearing their clothes and you can only see the abdomen, you may not see that they are catheterized because the catheter reservoir bag is on the bed rather than on the side. So these are all things to be cautious about and alert to. I'm going to be talking about stomas a little bit later on as well in the next few slides. So these are the scars that I mentioned. Try to memorize them if you can. It's not the end of the day if you can't memorize them, but I think it's always useful. And if you can visualize this image, that would be great for your ward-based learning. This here is a distended tummy. So as I mentioned before, that abdominal distension can be caused by a wide number of things. It can be caused by due to being fat, could be due to fluid, could be due to air, so flatus and farting, and then also feces, fetus if you're pregnant, and also if there's a malignancy or a fulminant mass. And here are the signs which are pathognomic for pancreatitis. So on the left side, you can see Cullen's sign. So Cullen's sign is bruising of the tissue surrounding the umbilicus, which is associated with hemorrhagic pancreatitis. This is not an acute sign. This is late, but if you see this, it's very it's highly indicative of pancreatitis. On the right, there's Gray-Turner sign. So Gray-Turner sign is more on the flank, and it is bruising of the flank, which is associated with hemorrhagic pancreatitis, which is once again a late sign. This would not be an acute sign. Perhaps one of you may be able to tell me in the chat box the different types of pancreatitis we have, and yeah, just once again to make sure everyone is alert and is focused. As I mentioned before, we will talk about a little bit of anatomy, but not too much anatomy. But I think what's really important about hernia is more about how to examine it. And I think the most important hernia that you really need to know how to examine is the inguinal hernia. However, we can apply the same structure that I will discuss now to other hernias as well. But in terms of an inguinal hernia, we need to inspect it first. So is there any swelling? Is there any redness? Is the patient in any pain as well because of the hernia? The second thing, is the patient, or can we ask the patient to cough? And can we see the hernia bulge through the opening in the abdomen? And are there also any scars present? You might be thinking, why scars? But that's because it could be due to, or it could be in relation to a previous open repair in the groin, or it could be a laparoscopy or a previous laparoscopy which caused an incision once again, which didn't quite heal and left a weakening in the abdomen for the hernia to protrude through. Once you've inspected this, then we can actually palpate. So as I mentioned, ask the patient if there is any pain, and let's examine the lump itself by asking the patient to cough and then feel the expansal cough impulse due to the increased intra-abdominal pressure. Next thing, we can try to reduce the hernia. If it's reducible, then we know that it is not, incarcerated, or it's not strangulated, which is usually a good sign for a hernia. Then we should try to relate it anatomically. So you might be thinking, why do we need to relate it anatomically? But that's because we need to know, what type of hernia is this? Is this a hernia which is in the indirect? Is it an indirect hernia, or is it a direct hernia? So the way we do this is we apply our finger on the pubic tubercle, and we ask the patient to cough. So if it's an inguinal hernia, usually it is superior and medial to our finger, whereas if it's femoral, it's inferior and lateral. Now, once we've identified whether it's a femoral or if it's inguinal hernia, as I mentioned before, then we need to figure out whether it's a direct hernia or if it's an indirect hernia. So the way we identify this is we place two fingers at the midpoint between the anterior superior iliac spine. So let's say that's there, and this is our pubic tubercle, and we put both of our fingers at the midpoint here. You could say at an angle, and you might think, why do we angle it? But that's because the inguinal ring is running along in that same same degree and same angle. And what are we asking? So if what it will do is, if at the midpoint between the superior iliac spine and the pubic tubercle, if there is an impulse felt there, it's usually in the internal ring, and usually if it's in the internal ring, and if we put our hands there, usually it prevents the bowel from actually protruding. Whereas if it's from the direct, or if it's a direct inguinal hernia, then even if we put our finger there, the hernia would still appear. And finally, we need to auscultate. Why do we need to auscultate? Because we need to make sure if there's any bowel sounds present. Because if the bowel is trapped in an hernia which is irreducible, or not, or it is reducible, but the bowel is there, we need to figure out if the bowel is functioning, and if the bowel's peristaltic movements are okay. Because if not, then this could easily be a sign of necrosis, which could easily lead to sepsis. So here, as you can see, here is this is a direct hernia. So as I mentioned before, when we put our two fingers at an angle, we're really we're usually angling them at the same angle of the inguinal ring. They're perpendicular. So if there's a defect in the posterior wall of the abdomen and bowel herniates through, that's a direct hernia, right? That's a direct hernia. If the bowel is entering through the deep ring, which is lateral, and then traveling through the inguinal ring, through the superficial ring, that is an indirect hernia. And an indirect hernia can quite easily travel into the scrotum, and that can also present as scrotal swelling, and it's very painful, and it's a very critical situation. So that was a little bit about hernias. Just to reiterate, the first thing you always do is you always inspect a hernia, you palpate a hernia, and then you relate it to the landmarks, or if there are any bony landmarks. And the final thing, you always auscultate for any bowel sounds to make sure that the bowel is functioning okay. And these are the different types of hernias. So you can have epigastric hernias, you can have umbilical hernias, Spigelian, which is quite a rare hernia, femoral hernia. Now, femoral hernia are very different to the other hernias because they have an increased risk of strangulation. So if a patient, for example, presents with a strangulated hernia, and as I told you before, when we place our finger on the pubic tubercle, and if the cough impulse is felt inferiorly laterally, it's a femoral hernia, and at that point we should take extra precautions and extra care to make sure that a femoral hernia doesn't progress to a strangulation. And as I mentioned earlier in the inspection of the abdomen, some patients, a lot of patients have got stoma bags. So as you can see here, I'm not going to go into what a stoma is because this is strictly essential examinations, but a stoma is usually a pouch which is artificially created due to bowel being removed. That's as much as we'll go into a stoma, what the definition of one is. But what's important here is we need to assess a few characteristics of the stoma. So where's the location of the stoma? The location of the stoma can provide clues as to the type of stoma that we're dealing with. So colostomies with colon stomy are typically located in the left iliac fossa, whereas ileostomies and urostomies from the bladder are usually located in the right iliac fossa. So left is colostomy, right is ileostomy and urostomy. So once we've distinguished the location and the type of bowel that is probably involved in this stoma, we can then assess the stool and the contents in the stoma. So this could be either stool or this could be urine. What's important here is that we try to assess the consistency of the stool. Is it liquidy or is it solid? And these are usually quite suggestive of the status of the patient. Now, in terms of spout, so colostomies are usually flush to the skin with no spout. By spout, I mean this little part of the bowel, which is actually hanging outside. It's not inside the body or attached to the skin. It's actually outside. And usually, in ileostomies and urostomies, there's a spout. But for colostomies, they're usually flush to the skin without a spout. Right. So with that, we've actually covered the inspection of the abdomen completely, and then we can begin the palpation of the abdomen. But before we palpate, we need to make sure, once again, that the patient is lying flat on the bed, that they are relaxed, and their arms are besides them, or to the side. And we also need to ask the patient, preferably beforehand, actually, the point or the site of the pain, if there is pain. Ideally, you should kneel beside the bed to palpate. This could be this is sometimes not the easiest of things to do, because if you're not confident whilst kneeling in terms of palpating and also observing the patient's eyes and the face throughout the examination, it can be sometimes difficult. So it's okay to stand as well initially at the start, but do try to kneel as well and then examine. And as I mentioned, we should always obviously observe the patient's face throughout. That's because they could show no signs of tenderness or guarding, but their face could be grimacing, for example, if you touch a particular spot. Now, if the patient can't relax, what we usually do is we ask the patient to turn the head away from the side that we're on. So, for example, if we're on the right side, we get the patient to turn left, and that usually does relax them. And last but not least, before we begin the palpation, we should work by region. So left upper, right upper, or we work by quadrant by quadrant. Okay, I'm not sure you can see this image very clearly. I apologize for this, but as you can quite clearly see, on the right side you have the abdomen broken down into quadrants, and on the left side you have the nine regions. So above the stomach, it's usually the epigastric. Umbilical is central by the umbilicus, and then under the umbilicus is obviously hypogastric. And all of these regions contain parts of organs or the only parts of the organs, and therefore, if there's any tenderness in that region or potential masses, it's very, very easy to identify what organ is affected or what you're feeling as well. So, palpation of the abdomen. What we should always do with palpation of the abdomen is we should start off with a light palpation first and gradually build it up to a much more deeper palpation. So in terms of a light palpation, we're going to palpate each of the 9 abdominal regions or the 4 quadrants, and we will assess them for tenderness, to see if there's any regional pain, if there's even rebound tenderness as well, which is usually when after the abdominal wall has been compressed slowly, that there's a sharp release of abdominal pain, which is usually a sign of peritonitis. If there's any guarding, so guarding is involuntary tension in the abdominal muscles that occurs on palpation, which is usually, once again, associated with peritonitis. Then also, if there are any masses or if there's signs such as Rovsing sign. Obviously, Rovsing sign is, historically, and it's the most well-known sign, which is linked to appendicitis, and it's usually due to palpation of the left iliac fossa, which causes pain to be experienced in the right iliac fossa. Obviously, you have McBurney's point as well, which is more specific for the appendix. After you've lightly palpated, then we can, palpate the abdomen a bit more deep. So once again, same concept. We're palpating each region, but we're applying a bit more greater pressure to better feel for masses. And if you feel a mass, then what's important is we describe the we describe the characteristics of the mass. So we need to note the location. Which region did we find it? What part of the organ do you think it could be? Its size and shape, approximately. We usually do this using our fingers. Consistency. Is it smooth, or is it soft? Is it hard, or is it irregular? Is it mobile? Can you move it, or can you not? And finally, if it's of vascular origin, is it pulsatile? Can you feel a pulse? Usually in the abdomen, this is usually centrally felt if it's a pulsatile mass, and it's usually an abdominal aortic aneurysm. All right, so palpation of the first organ. So we'll start off with the liver. So with the liver, we begin the palpation in the right iliac fossa, starting at the edge of the superior iliac spine, using the flat edge of our hand. So the flat edge of our hand is basically the radial side of our hand. So using this side, if this is the abdomen, we're using the flat end, and we're basically palpating the abdomen like this, with the radial edge of our hand. Then I've lost my mouse here. Then we ask the patient to take a deep breath in and apply pressure to the and we apply the pressure to the abdominal wall with a hand to try and palpate the liver. If you cannot palpate the liver, you should move our hand 1 centimeter closer to the costal margin. This might negate this. If we feel a liver which is increased in size, it's usually known as hepatomegaly, and there are many different causes of hepatomegaly, which I won't go into, but it's always useful to know. Masses, once again, liver masses, not usually common for primary liver disease, but usually more for secondary. And if there's tenderness, which we've got to, yep. And if there's tenderness, it could be hepatitis, for example, if it's tender. So this is how we palpate the liver here. We're starting from the right iliac fossa, superior to the superior iliac spine, and using the flat radial edge of our hand, we are palpating the abdomen. So after the liver, logically we would try to palpate the gallbladder. So in terms of palpating the gallbladder, usually if you're a healthy individual, it's not palpable and it shouldn't be palpable. However, if there is a palpable gallbladder, usually suggests enlargement secondary to biliary flow obstruction. So this could be gallstones, could be infection, cholecystitis, and it can also be pancreatic malignancy as well. And usually we attempt the palpation of the gallbladder at the right costal margin, usually in the mid-claviculine, which is usually the tip of the 9th rib, and if the gallbladder is enlarged, usually it is a well-defined round mass that moves with respiration. So this could be when you take a deep breath, the gallbladder is actually more palpable and it's moving. And obviously, as I've mentioned, we're assessing for tenderness and masses as well. There is a specific sign associated with the gallbladder, which is known as Murphy's sign, which is indicative for cholecystitis. So here you can see Murphy's sign. So Murphy's sign is to try and summarize how to palpate the Murphy's sign. We would position our fingers at the right costal margin, the mid-claviculine, once again, and ask the patient to take a deep breath. And once they take a deep breath, we will be able to palpate the gallbladder, and this would usually give us the sign that this is an acute cholecystitis case. Onto the spleen. If you're healthy, you really shouldn't be able to palpate many of the organs, to be completely honest. So yeah, the spleen is no different. Shouldn't be able to palpate it. However, if we are palpating for the spleen, once again, we should begin the palpation in the right iliac fossa, far away from the costal margin. Once again, we're using the flat edge of a hand, and we ask the patient to take a deep breath, and then we palpate the region with our fingers aligned with the left costal margin. If it's not palpable, once again, we move 1 centimeter closer. And the reason why we palpate for the spleen is if there's any splenomegaly, which is usually linked with hepatomegaly. And once again, the causes of splenomegaly I'm not going to go into, but it could be portal hypertension, it could be anemias as well, heart failure, etc., etc. So this is how you palpate the spleen. We're starting from the right iliac fossa again, asking the patient to take a deep breath in, and then we're palpating the spleen. The kidneys. So usually with the kidneys, we are using both of our hands, and as a result, we call this bimanual palpation or balloting. Balloting isn't usually commonly used, it's usually bimanual palpation. Just to repeat myself, no organ is usually palpable if everything is okay, and the kidneys are also no different. But if an individual is asthenic and very thin, and they have a low BMI, the kidneys can be felt. And the way that we start the bimanual palpation is by placing one hand behind the patient's kidneys, below the rib, and then you press upwards, whereas with the other hand, we press downwards from the abdominal side. And usually what we're trying to do here is we're trying to feel the lower pole of the kidney whilst the patient takes a deep breath to assess the shape, size, and the consistency of the kidneys. We're trying to assess if there is enlargement of the kidney. So causes for enlarged kidneys could be polycystic kidney disease. It could be due to renal tumor, and a number of different reasons as well. Here's a palpation or bimanual palpation. So as I mentioned, one hand is to the back and we're pressing up, and the other hand we're pressing down on the abdominal side, trying to feel the lower pole of the kidney. This is one of my favorite things. I think quite a lot of students' favorite thing to do is on the image here. It's really a fist, but you can karate chop it as well. And this is usually for percussion more rather than palpation. But we perform this this karate chop or percussion for the kidneys to see whether there is an infection or if there's increased sensitivity and tenderness, which is usually seen in pyelonephritis. So this is the fist percussion in this image, but you can call it a karate chop as well. And then onto the palpation of the urinary bladder. So what's important before we start actually palpating the bladder and irritating the patient, we should ask the patient whether they would like to go to the toilet, because as I mentioned, performing the examination after it, the patient may have the urge to go to the toilet because it is quite uncomfortable. It's not usually palpable in healthy patients. However, if you have a full bladder in the form of distension, retention, and obstruction as well in the urinary tract, it can cause bladder distension in the suprapubic area. And here's I couldn't find a very good image of someone palpating for the urinary bladder, but I think you can use your imagination here to find out where you would palpate in a male and a female the bladder. And then the final thing that we'll be palpating is the aorta. So for the aorta, we're going to use both of our hands. And what we're going to do is we're going to perform a deep palpation superior to the umbilicus in the midline with both of our hands to try and palpate the aorta. Usually pulsations are normal because it's the abdominal aorta and it has a very high blood flow rate. And as a result, there will be a pulse possible. There will be a pulse felt, rather. However, if our hands move outwards when we're deeply palpating the aorta, this is usually indicative of an expansile mass. So this expansile mass is usually an abdominal aortic aneurysm. And it's the whole palpation of the aorta is quite a crude clinical test, and as a result, you would definitely need more extensive investigations to confirm the diagnosis of an abdominal aortic aneurysm. But if you can palpate the aorta and there's an expansile mass, this is usually usually gives us the go-ahead to investigate. In this next image, you can see what we're doing with our hands and how we're actually palpating superior to the umbilicus in the midline. And it's a deep palpation rather than a light palpation. So with that, palpation of all of the abdominal organs is done. And now we can move on to percussion. So percussion is an important portion or part of the abdominal exam, and it consists of tapping on the body wall and trying to elicit a sound which has different pitches for different structures, and the changes in the pitch differ depending upon the organ being percussed. So how do we percuss? So we ask the patient to lay and relax on the bed, once again with our arms aside, and using our non-dominant hand, as you can quite nicely see on the image here, using our non-dominant hand as the base, and using our dominant hand, we tap on the dorsum of the middle finger here, twice usually, and then we assess for any dullness, or if there's any shifting in dullness as well, and tapping during percussion can also cause the movement of fluid, so it's usually a wise option to percuss every single area or every single region of the abdomen. And now what we're going to do is just going to discuss a little bit about percussion of a few organs in the abdomen. So in terms of the liver, usually we percuss upwards, usually 2% at one time from the right iliac fossa all the way towards the costal margin, to see if there's any percussion note changes at all, to see if there's any fluid in that region. And we keep on percussing all the way up to the upper liver border, to try and see if there's any fluid behind the liver as well, not just in front or superior and inferior to it. That's what we do for the liver. For the spleen, once again, it's the same concept. You're trying to make sure that there's no fluid posterior, superior, anterior and inferior as well. For just in terms of shifting dullness, I've mentioned here, shifting dullness is usually a sign of ascites. So percussion can obviously be used for any fluid, and ascites is fluid. So percussion is very useful for assessing the presence of ascites. And what we usually do is we percuss from the umbilical region to the patient's left flank, and then vice versa to the other side, all for 30 seconds. And what happens is if ascites is present, the area that was previously dull should now be resonant due to the shifting of the dullness, because when we're tapping on it, the fluid is moving to the other side, and the other side is remaining dull. So this is shifting dullness. Usually we use it for assessing ascites. Here you can see a nice visual representation of a doctor percussing all the regions of the abdomen and the quadrants. All right, onto the final few topics. So the penultimate one is going to be auscultation of the abdomen. So auscultation is usually undertaken over two random points on the abdomen, and this can be anywhere in the abdomen. If the sounds are normal, they sound like gurgling or gargling or haven't really described that very well, but I think you know the sound it makes. It's very gurgly. There's tinkling. This could be linked with obstruction. And if they're completely absent, this usually implies dysfunction in peristalsis, which is suggesting ileus. And we obviously know that there's many different causes of ileus. It could be due to recent surgery, could be because of electrolyte abnormalities as well. And to be able to confidently say to a patient and to report to a doctor that you couldn't hear bowel sounds, you really need to auscultate for about 3 minutes. So this is probably one of the most time-consuming parts of this exam. It is very important that you do it properly. And we're not just auscultating the bowel when we talk about the abdomen. We're also auscultating for vascular structures as well, such as the aorta and the renal arteries. So auscultating for the aorta usually is undertaken 1 to 2 centimeters superior to the umbilicus, once again in the midline. And a brute here, which is a harsh, turbulent blood flow, is usually associated with a triple A. A renal brute, or for auscultating the renal artery, for any pathologies, usually we once again auscultating superior to the umbilicus, but more lateral to the midline. And once again, a brute here, which is turbulent blood flow, is usually associated with renal artery stenosis. Here you can see a nice image of a doctor auscultating the bowel, and then on the right you can see the landmarks which I just mentioned for the aorta. So the aorta is 1 to 2 centimeters superior to the umbilicus here, and the renal artery is once again 1 to 2 centimeters superior to the umbilicus, but a bit more lateral to the midline. And that is the area for auscultating the vascular structures. Now on to the last topic. It's certainly the last topic, but it's not the least of any of any of the stages of the examination that we've talked to. And it's a very important part of the exam, but it can also be very awkward to describe and then to perform confidently and effectively. Just because it's awkward, we shouldn't avoid it, and also because we as students, we're not really exposed to it in many contexts, or we're not usually allowed to do this. So we shouldn't shy away from it, but if you can, I would, because it's a very important thing to learn and to master. And just because it's awkward and unpleasant for the patient, you should also not avoid it, because it's very important, for patients with symptoms of PR bleed, tenesmus, or change in bowel habits and things like that. So the first thing before anything that you usually do, which is in or that is potentially impacting patient dignity, we should explain the procedure and we should gain the consent. So we should explain what we're going to do, how we're going to do it, why we need to do it, and then ask the patient if they consent to us doing it. What can sometimes alleviate concerns is if we offer a chaperone. So that can sometimes calm the patient, and they can be a bit more cooperative after that. After that, we should gather our equipment. We should gather gloves, some lubricant, some tissues as well. possibly and a tray as well. We should also make sure that there's good enough lighting, and that's because there could be some lesions around the area which may not be identifiable if there's not good enough light. And then before we inspect, and when the patient has pulled their trousers down or whatever, we should consent again before examining. I can't keep harping on about how important it is to gain consent for this procedure. And usually, when the patient has uncovered themselves from the waist to the knees, we usually ask the patient to lie in the left lateral position, and we try and get them to bend their legs and bring the legs right up to their chest, or the knees up to their chest. This usually relaxes the anus more, and it allows the doctor to nicely examine the rectum and the anal region. So, as I mentioned before, we need good lighting because to inspect the perianal area before we place our fingers inside the anus. We're inspecting for any lesions, any warts, for example, for any viral infections. Once you've done that, then we can put our finger inside the anus, and we can assess sphincter tone. Is there good tone? Is there poor tone? Once again, if you'd like to know more about tones, you can head over to the neurological lecture, which was the first one in our series, to better understand about muscle tests and sphincter tones. After that, we rotate our finger covering the full 360 degrees to assess the entire region to make sure that there's no lesions, there's no mobile masses, there's nothing that we can palpate. And when we're done, we obviously pull our finger out. We should never deglove quickly. We should always inspect the glove after for any signs of blood, feces, or mucus as well. So here is a very descriptive picture, you could say, of how a PR is performed. I apologize for the anatomical, or for me not providing an image for a female as well, but the anatomy is not too dissimilar. Obviously, we must make sure that we're not palpating the vagina instead of the anus, but I think that we're all intelligent individuals here, and we would know what's what. And yeah, PR is very important, as I mentioned, for PR bleeds, any of those altered bowel habit symptoms, but also in urology for palpating the prostate as well. So yeah, and with that, I think that's the end of the lecture. Thank you all for your attention. I've also added my email here. If any of you would like to get in touch, if you have any particular questions about this exam or the neurological exam, or anything else in general, I'll be more than happy to help you. In terms of what we have lined up next, I'm really excited to say that we will be talking about PEDS next week in the form of a general pediatrics exam. We will be joined by another UK doctor, and Dr. Jervis will be describing the pediatric exam in a really simplistic way. So that'll be really useful for everyone learning pediatrics. Also have a respiratory exam coming up, and we also have a cardiovascular exam in a few weeks. And day by day, we're confirming more and more events well into June and July. We'd just like to take a moment to once again thank our fantastic sponsors and our partners for all of their support and generosity. So, for example, os implants, MySuture, QuesMed, Anastomose, Medal, and pod cases as well by Scrubbed In. We're very thankful for their support. And the moment that most of you have probably been waiting for, the feedback form. So here is the link to the feedback form. I will also add it to the chat. Yeah, if you could all just scan this QR code to then fill out the feedback form and also automatically be entered into our prize draw at the end of July. That'd be very, very nice, and we appreciate that greatly. So with that, I will stop sharing my screen, and I would just like to say thank you, everyone, for giving up their evening to watch this lecture. I hope this was really informative, and I hope you find this useful. This will be uploaded onto YouTube when we finish. And yeah, you can watch it as many times as you want. We will also be uploading the slides onto Medal, and also the video recording of this. And yeah, thank you very much for all of your participation. And I hope to see you at the next one next week for pediatrics. So thank you very much, guys, and I hope you have a great evening. Thank you.